The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon and welcome to our third session of our Belgian eHealth Interoperability Days during the online IHE-Europe Connectathon week. We are glad that you are here again online. I am happy to announce you two speakers and experts from IHE-Europe, Charles Parizeau and Jürgen Brandstetter. They will talk to us about IHE profiles on HL7 FHIR today. I would like to go over some practical things right now. So please don't hesitate to put your questions in the questions section. We will address them at specific points and at the end. The presentation will be sent to you by email in the upcoming days. The recordings will become up online in a couple of weeks. If you have other remaining questions, join our closing Q&A session tomorrow at 4 p.m. And also do not hesitate to check out all of the other interesting sessions that we have tomorrow and on Thursday. Thank you. I give now the floor to Jürgen. Thank you very much, Jürgen, for being with us today. I make you presenter right now.
Yes, thank you. I received it. So you should see, you should see it now. Yeah, welcome everybody. Thank you very much for attending this workshop. Charles and I will try to give you a comprehensive overview on the IHE profiles, which are based on HL7 FHIR. We just have hopefully enjoyed the introduction sessions right before. So after this presentation, you should better understand the IHE role of in interoperability and also how FHIR is used in IHE profiles and the IHE collaborations we maintain with HL7 and TIMS, for example, on to advanced FHIR. And these slides were initially developed by John Murky. You might know he is one of the gurus active in IHE and HL7 and dedicated FHIR specialist. So, IHE. This is the situation in reality. So you have eHealth projects on the right side, and you have a bunch of base standards on the other side. And the question is, how do you use them for the eHealth projects? And the promise we give, I mean the standards community, is that we have everything ready for the projects to succeed. But can we really realize this promise? Actually, just like that. 20 years ago, we saw that this was actually not the case. And there was something needed in between, a kind of a profile layer, and IHE was established at that point of time for that, and Continue was one of the other organizations following. And other organizations are profiling at the moment as well. But the point is, you need something in between the base standards and the eHealth projects. And this proved to be very important in practice for interoperability to be successful. So IHE is a very broad and very international organization. So there is an overarching IHE international body, which is headed by the IHE International Board. And below that, we have two different areas. The one is taking care of the deployment, and the other one is taking care on the development. And with development, we mean the profiling of the eHealth use cases. And the deployment, of course, is how to get that into the field, how to get that into real life projects, into real products in the different countries. And you see there are a couple of regional deployment committees, as we tell them, regional or national ones in Europe, Europe, but also Asia, and of course North America. And on the right side, the development of the profiles divides into different, as we call them, domains. All started with the radiology domain, IT infrastructure was falling right after, and after that, piece by piece, we get more of the clinical specialties like laboratory, pharmacy, cardiology, and so on. And all of those focus on their specialty in the medical area and profile the different eHealth use cases they have. The IHE methodology is actually an ISO standard, so it became that a couple of years ago. It's divided into 3 parts: technical report 28380, 1, 2, 3, and basically this is the cycle IHE follows with its methodology. So the use case out there comes to the standards layer to us, and the working group starts to deal with that and writes down, what is this use case? Is that a global and globally common use case, or is it just for this particular region? And many of the use cases are pretty common, so it's not so much different as you might think. And this commonality on a global scale is distilled out at this point of time in the profile development cycle. So the first part, so to speak, our first pillar is the profile development. But that's not all, because to get the systems enrolled into practice, you need a lot of serious stuff, like, for example, testing. And the testing is also a very cost-intensive endeavor. So also the testing is one of our pillars, the second one, and it's an integral part of the IHE profiling cycle. So the first testing on IHE level is directly playing backwards to the profile development to make the profiles better and so on. And after you have stepped through that, the intent is that products compliant to those IHE profiles meet the different projects, which include that in their RFPs, and so leverage all of the cost savings and efficiency. So the principle is, and I'm showing that on FHIR, is that projects around the globe are discovering use cases which you would like to handle, and they pick standards as they want. For example, FHIR resources, as we just heard before, and so on. And there are simple ones where just FHIR is used, but sometimes you have to combine standards to fulfill a particular eHealth use case in practice. And the result is that we often see that we have globally different solutions for the same. So this gets better because also we have a profiling level also already on the HL7 FHIR side. But before FHIR, this was a very, very big problem. Now it gets better because more organizations are engaging into that profiling. But if you don't do that, you get basically a different solution for the same thing, which is bad. So we, IHE, is plugging in between, and we identify these interoperability use cases and try to convert them into some building blocks. So the standards do not go directly to the projects, they go first on our level, will be packaged in the way that they can also be combined with other things. For example, if you want to identify patients, you might want to log that at the same time. So you always need combinations of these different things, and often you reuse things like the logging. It's not only for identifying a patient, but it's also you want to log the thing if someone is accessing your health data or something like that. So it's the point is to create the reusable building blocks. This is important for simple use cases where only one standard is involved, but anymore if there are more than one standard involved, because the packaging and how they are combined is done on the standards development level and not on each project level separately. And the consequence of this is that each project just has to deal with their country-specific extensions, and they can rely on this thick base layer, which actually covers the 80% which are usually common globally. You can rely on these tested products and on a market, on a global market, which ensures competition and in its tail, the cost savings and sustainability. So more or less, you get globally similar solutions for the same. They are not 100% similar, but they are as similar as they can be. And every percent which you can save because you are on some kind of best practice, which everyone is using, is actually a lot of euros in money which you save on all ends you have to do, from the tendering, the testing, and the maintaining and everything. So it's all about cost saving, because this is actually really important with the increasing size of the eHealth projects. So this is now in detail what should happen. So we have the standards, the base standards on the ground. There's old or the mature HL7 V2 standards, for example, or LOINC or SNOME, DICOM, or FHIR, and they should be profiled, or we do profiling them and divide them into the respective actors and transactions flowing in between. And those should be leveraged by the eHealth projects in their interoperability specifications. And what happens then is that these profiles serve for vendors to create software which then be tested at IHE connectathons product-wise, or let's say product-wise, or premature product-wise. And the step further is that they go to one step further and do a conformity assessment, which is a real independent lab-proof check of the conformity of the product in a specific version and so on to these profiles. And at that point, they should meet these eHealth projects for which they tender for and test the last bunch of differences for the respective project in what we call projectathons. And all of this testing is one of our core competences and where we want to contribute to interoperability in the field. So these again our IHE domains. But before we come to that, I think we have a poll prepared, Colleen.
Yes.
You see a short poll. We would like to know from you about what you just heard, to which extent you agree that IHE acts kind of in a way of standardizing, really up to the point of testing and deployment of real projects. Do you think that's very crucial for to maximize efficiency and minimize costs as we think? Or do you rather see the benefit, but you would feel that would be equally good in another way? Or would you even think that we are totally on the wrong track and should actually stop doing that? So I'm not sure how long the participants have time to fill that, but you give me a sign once I can continue with my slide, okay?
Yes, please. You have 5 seconds remaining. Please input your vote. We will show the results very shortly. Okay, no more votes are coming in. Oh, yes, there still is. I'm going to close the voting right now.
Oh, great. Thank you very much. Oh, that's good. So thanks for confirming that we are doing right. And indeed, we have seen that actually in practice in some different countries where this principle was lived to the more or less extent. We have seen that the more you proceed in that way, the more you can gain some profits in terms of cost savings. And you really see that in every single corner of a complex project. And you start on working groups, but also when you write your tenders and then you check your tenders and then you negotiate with your vendors and so on. So Colleen, can you go to the slide? Yeah. No? Colleen, that's wrong. I should continue now. Okay, thank you very much. Yeah, okay. So we are now see a list of the IHE domains, and you see the orange ones are the ones who are already have developed some profiles leveraging the new FHIR standard for most IT infrastructure and patient care coordination, but quality research and public health has been very active as well. And you see that kind of driven by the past, you have the word mobile in the title of the profiles very much. This originated back some years ago, where FHIR was mainly intended to be used by mobile devices. In the meanwhile, we see that FHIR is a general purpose new standard, which of course can also be used for other purposes as well. So please don't let you confuse about this term mobile. Of course, all these profiles mentioned can be used in any setting. It's not restricted to use with a mobile device. And this is kind of the bunch of profiles which you have as a headline here in acronym. You see there are quite many in those 6 domains. You can see the exact list on this link. The FHIR-based profiles in IHE are marked with the FHIR symbol. And with that slide, I would like to hand over to Charles, who is now drilling into the to the most important FHIR-based profiles. Explains. Thank you very much.
Thank you, Jürgen. I don't see my...
You were sharing the screen, Charles. You were sharing the PowerPoint, yes.
Oh, I'm sharing the PowerPoint. Okay.
Yeah.
Yep. Sorry. I have to get use of the variant of this tool. Thank you very much. Jürgen, this was indeed a nice introduction to explain how it has been IHE's concern for many years to create an efficient flow end-to-end from the need all the way to the solution, and try to reduce the complexity of applying standards. So what I want to do now is to walk through this myriad of FHIR-based profile. There are 33 profiles, if I counted well, to the last count, and we will not go through all 33. So don't be scared. We've picked a few of them that are of more relevance, or that have proven more general interest. So, okay. So as we go through the five of the 6 IHE domains that have a device profile on FHIR, this is the list for IT infrastructure. IT infrastructure is a special domain. Most of the other domains in IHE that are developing a profile responding to use cases that are submitted to them by the user community are essentially clinical in nature. We have a laboratory and pathology domain, a radiology domain, a patient care coordination domain. IT infrastructure is dealing with all of those profiles that are in such a generic sense that they can be used in multiple and with various clinical content. So let's walk through the top 5 that are bolded on this list, and start with the mobile health access to health document. Many of you are familiar with the XDS, the cross-enterprise document sharing. There are a number of sessions into the Belgian Interoperability Day on XDS, and if you've not heard yet about it, we will speak a little bit about XDS. But the fact that XDS was a web service, so based approach which was we still the wide deployment of large-scale systems are using SOAP-based web services. As RESTful deployment is becoming of interest to many implementers, as Jürgen said, not only in the mobile space, it became obvious that having a FHIR interface, a RESTful interface, and more precisely the flavor of REST that FHIR has developed, that is what the profile is doing, and is defining ways for a document recipient to a document source to transact and submit the document to a document recipient. This document is, the content of this document is not defined by MHD like it was not defined by XDS. To the contrary, MHD is designed so that it can support many variation and many variants of content. Likewise, the document consumer on top is querying and retrieving documents from a document responder. And if you take the MHD interface and you apply it to an XDS environment that you show with those 5 actors in the middle, the source, the consumer, and more importantly, the document registry and the document repository, that's the deployment of XDS, which sometimes has a single repository, sometimes has multiple repositories, and even sometimes has multiple registries that are federated and create large-scale deployment. Today, the largest network based on XDS and XCA, the cross-community federating document registry, is in the US nationwide, and it's connecting half of the US care delivery facility with 150 million patients being addressed. So we have, and we see very large-scale deployment of the IHE document sharing. It's in use today, and we have many of those in Europe, in Switzerland, in Austria, and so forth. Now, having a FHIR-based interface to this has been a request from many, and this is where we have MHD coming into play. If you tether a MHD document recipient with a document source, the MHD document source sees the XDS environment with a FHIR interface and can submit and share documents in that sharing environment. Likewise, the MHD document consumer with a document responder group with the document consumer of XDS is able to query and peruse what's on the document registry and pull documents out of the document repository. So you can have an already deployed XDS and add this FHIR-based interface so that system connect either way, traditional SOAP or FHIR way, and gives you that flexibility where you have the flexibility of XDS with the large-scale deployment in the middle, several repositories and multiple federated architectures, and you have the simplicity of the FHIR interface on the edge. So that's why the MHD profile is very often nicknamed XDS on FHIR. There is another profile I would like to spend a minute with you, which has to do with a question that is often asked is, hey, if we do document sharing, we cannot access the data in a fine grain. The only thing is to get to access our documents. And documents are nice, but I need to look at to read the entire document to find an allergy. That's a lot of work. And if I have allergies in many documents, then I need to bring many documents and process them and extract the allergies. This is a complex work. And the answer to that is no. You may do this, you have the flexibility to do that, but you can also combine the ability to have queries on specific data elements, or what FHIR could call resources, and extract those out of the shared infrastructure. Let me show you how it works. We have a document that are contributed to one or more repository. This repository is providing those documents to what we call a clinical data source. That could be simply an interface. There's a need to be a separate database, but the clinical data source responds to query. In that case, I have an EMR at the bottom that says, please, transaction number 2, I would like to see a list of allergies for those patients. And it is the central clinical data source that is going to go into the document repository and extract from the documents the allergy entry and return a list of allergies. This can be done on the fly. This can be done with a duplicate database that is organized as resources. Both implementation exist. Both implementation have benefit. But where things get very interesting, and that's what IHE does when it speaks to clinicians. Clinicians say, hey, yes, allergy 1 is interesting. However, could I have a level of trust? Who noted that allergy? When was it collected? In which context? Was it verified? So what you can do with the profile MXDE is to issue a request to say, I have an allergy, I have a reference, and I would like you to give me the document from the document repository that contains that allergy. And that retrieve response comes back to the querying system with the transaction number 4. And now a patient summary is being displayed where that allergy was extracted from. But now the clinician sees allergy in context. I see problem, I see procedures, I see lab, I see that this allergy was detected and verified in the course of a hospital stay. So I have a high level of trust in that allergy. It was not only mentioned by patient as to a physician in the course of a community encounter. No. That's in a sense a verified allergy. So getting the ability to both query for a list of allergy, list of problems, and then go and see those in context of the document. We are actually marrying FHIR resource-based queries and document-based queries and retrieve. And that's what MXDE does as a cross-enterprise document data extraction. And this is proven very effective, and we're beginning to see some deployments of MXDE. So I move now to another profile, and I'm sorry to switch you, but to give you a sense of the breadth of what IHE has done with FHIR. We had a problem that was submitted to us a couple of years where people said, hey, sharing clinical documents is great. My problem is I have files that I need to share. They could be templates, they could be forms to collect data, but those are not patient-centric. They are community resources. And I need to be able to manage those, make them available, and be able to contribute them and query for them and consume them. Now, yes, I can do that on a browser manually and walk through and see a list of things and all of that. However, I would like to automate this and integrate this into my EMR so that when I ask my EMR a certain form to do some public health reporting, my EMR doesn't need to copy that form and have a copy that is sometimes outdated. It can actually go and get it from a community or a nationwide resources and bring it into my system. So to do non-patient file sharing is something that we did, and we found that using FHIR to do that was actually a very convenient and practical way. Remember, IHE is not focused on any single standard. It's always picking the best standard for the use case at hand, and that's how NPFS-M was born. Two other profiles on patient identity, the patient demographics query, PDQM, based on FHIR. Many of you may have heard of PDQ that IHE has offered and deployed across many countries on HL7 V2, widely used in hospitals, in HL7 V3, used by many national programs today across the world. And we now have a PDQ-M, which is PDQ on fire, that has the similar properties as PDQ, and you can have a patient demographic supplier that actually is serving patient demographics both in FHIR, in V2, and in HL7 V3. So that's the PDQ-M. And likewise, when you need to match a patient ID against another patient ID in another domain, you need an MPI or a patient ID cross-referencing interface. So that's what PICS does, and PICS is in V2, is in V3, and is now available in FHIR. So that gives you a sense of some of the profile. I chose 5 that the IT infrastructure domain has developed. Likewise, with the other domain, in radiology, radiology was faced with a use case, which is it's increasingly important to develop the productivity of radiology department. The radiology department have to be operated upon request, orders, demand, and respond to those demands as quickly as possible, both in imaging and in reporting. How do you understand the flow and the bottlenecks in your radiology department? And that's what the SOL profile does, which is allowing the support of events and logging events that happen in the performance of various steps inside radiology, and to centralize those log of events, and so that you can do analysis and understand where are your productivity bottleneck in your radiology department, depending on the study, depending on the time of day, depending on whatever you want. So you create that log of events, and we standardize the interface so that the various systems that are used in the radiology department can contribute to these log of events. In passing, I would like to mention that REST is not only FHIR, and thinking that everything will be done in FHIR one day is actually an incorrect assumption. There are other important RESTful development. One of them is DICOM Web, and DICOM Web has been designed to be very complementary to FHIR, so that you can implement both in conjunction and do in FHIR what FHIR does best, and do in DICOM Web RESTful what the DICOM Web does best, which is essentially accessing, manipulating, modifying the rendering of images, doing the imaging-centric type of activity, and combining those with FHIR is indeed powerful. I will not further discuss it, but I list 3 profiles that perform this, and you find some FHIR resources that are associated with each one of those profiles. We spoke of the standardized log, so I can move on that. I would like to move to the pharmacy profiles. There too, 2 profiles were developed on FHIR, because FHIR was definitely the best solution. One is in the mobile space and on the medication administration space, and the other one is related to barcode. The medication administration is responding to the following problem: is how can you provide a simple interface so that when medication is administered, for example, at a bed of a patient in the hospital, you can query for what is to be administered, and once you've administered what is to be administered, you can inform back the medication administration consumer actor with a report on administration result. So you now have an administration system, which very often is a mobile system used at the point of care, knowing and reporting on what has been administered. A very important profile, and we found that this profile was useful not only in hospital, it can also be used in nursing home and in even in some community care or social care, where elderly are being assisted in their administration of medication. many barcodes associated to medication, and this is a profile UBP that allows you to have a well-framed FHIR transaction so that you can package the barcode of the reader and go to the processor, and therefore have a standardized interface to do this, which is done today in a myriad of incompatible ways, and that's what the IHE has tried to address in the pharmacy domain by the UBP profile. We are
Charles, I can't hear you anymore. It seems you have an issue with your connection. Jürgen, can you continue?
Wait a second, I'll try to pull up my slides.
can you hear me?
Yes, Charles.
He's back.
Okay, I'm sorry.
Okay.
My PC gave me a blue screen and is now taking a dump, so I need to switch to my cell phone.
So
So maybe Jürgen, you can
yeah, then I
continue
share
to
the
move the
screen
slide.
and yeah, sure. Yeah.
I was at pharmacy UBP.
Yes. So let's see. Yeah. You see that? Yeah. Yeah, the slide is on, Charles.
Okay, yep, thank you. I see it very well. Could you move to the next slide?
Mm-hmm.
Okay, the next domain we want to cover is patient care coordination. Patient care coordination is a domain where we are not dealing with a single specialty, but we're trying to deal with workflows and problems that cut across the community of care. So that's what this domain is addressing, and there is a number of FHIR-based profile from the IHE patient care coordination domain that we would like to share with you. Next. So the first profile, the profile we're going to be discussing are the top 5. There are many more here, but the first 2 profiles, for the sake of time, I will move quickly through them, are in the care, planning and care team management. Then we will cover the international patient summary, and then we will deal with 2 profiles that are in the space of patient transport, both between facility with RIPT and between emergency vehicle to a facility. So those 2 are in the transport space. Next slide. The dynamic care planning is essentially allowing you to create, manage, and update care plans. And this is important as you coordinate care to have the ability to perform those tasks. So it's a rather dynamic, rather effective profile to deal with this, and is finding a fair level of application into community level coordination, where hospitals and referring physicians are working together in a region or in a community. Next. Because if you do care planning, you basically have care team, and managing those care team so that you can select an initial care team as you develop the care plan. Oh, we came back. I'm not sure why.
Yeah. 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 No, it's lost presentation mode. Why? Sorry. Is that this one?
Yes.
Here.
Right. So, and allowing a care team to have members being added as the care is progressing, giving a patient to see who is his care team, to contact the right physician with the right specialty based on the care the patient receives, as well as the members of the care team know about each other. So a very interesting FHIR-based profile for community level care. Next. The International Patient Summary Profile is a very different profile. We have in IHE a number of summaries of different types for personal health records, for hospital discharge, and so forth. And the new development has happened over the last few years, which is to consider in large national program what is the content of a patient summary, and to analyze this content and create a patient summary which is built from deployed and experience in those type of patient summary. And that has resulted in a collaboration between SEN and HL7 in creating the requirements. It's SEN who did most of the work for a patient summary that would be pretty much able to cut across different countries, and to have HL7 be able to express those patient summary both in CDA and FHIR documents. And then IHE picked up there and in a sense filled the gaps. It found that there was area where some freedom was left, some area were not sufficiently precise, defined, and filled the gaps and created an international patient summary, which is absolutely compatible and based on the HL7 SEN collaboration work, and is now in the process of finalizing this and developing test tools in order to test compliance to this international patient summary. A major effort, and you see a collaboration between SEN, HL7, and IHE, and this is an important effort. Move on. So in the transport, I will go very quickly on those, doing interfacility transport, allowing a facility to interact with another facility in order to coordinate and plan such a transport. Next. Same thing between an emergency vehicle and a destination, let's say hospital or emergency center, and this allows the emergency vehicle to interface and transmit as much as possible information known on that patient ahead of its arrival, so that at the time of arrival you don't waste time to enter this into the local medical record system. It has been pre-fed from the ambulance with the necessary screening from the hospitals that is going to receive that that patient. So that's the ETF profile. Next. So we are now entering the last domain, quality, research, and public health. 3 different subdomains that we've put together because we found that the issues that quality, research, and public health have are very similar, and they are dealing essentially with secondary usage of the data, either for quality measurements, either for research, or for public health action, both on planning and reaction. So here is a list of profile. I don't have enough time to cover them, but you see that we have 4 profile. The mobile retrieve form for data capture is a very interesting profile which allows a medical record system to have an entry for a single interface which is a very specialized browser type, but for data capture, used for public health and used for research, so that you can actually pull a data capture form from a remote system, associate with it local information, pre-fill that form with clinical data, and then manually fill only what is necessary in addition, and then feedback that filled form to a form management system. In doing so, you can adapt a clinical system with very, very minimal modification to become a data capture system that has a good level of automation and is no longer forcing clinician and staff to re-enter information from one system to the other. Then we have the vital records, the death reporting, the birth and fetal death reporting, very important to link care delivery and the management of vital records, and for both babies and adult. And last but not least, a generic profile, but that is a foundation profile for a quality outcome reporting for emergency management systems. So 3 profile. I will skip the slides and hand over to Carleen for the last question.
You want me to line?
Polling.
So we have another poll. Go ahead and click on the screen. You can select multiple selections. So please vote.
And this is, important for us to give us a sense of where do you see the need, the most important needs in the real world.
I see the votes coming in. So a final 5 seconds for you to vote. Go ahead. Last chance. I will close the vote and I will show the results. Charles, up to you. Is it what you expect?
Thank you very much. Thank you for your feedback. Very, very useful. Yep. Oh, thanks a lot. I want to pass the ball back to Jürgen.
Okay, I make
Yes, thank you. No, I'm already presented. Just remove the poll results. Yes, I know what happens when someone's doing something at the controls, then I lose my presentation mode. Okay, so thanks, Charles, for doing that explanation of the FHIR-based IHE profiles. And I want to close that slot now with the remaining few minutes with some collaborations which IHE has with other organizations, most in forefront, of course, HL7. So I would say about 2 years ago, there was the idea to do something to bridge the gap between IHE and HL7 on the topic of FHIR, because those were times where there was a lot of confusion around. It's either IHE or FHIR and all of those things. And this confusion among the deep insiders of the 2 organizations was very uncomfortable, and that's why there was a high-level decision to start a joint project or a joint initiative. We gave it the name Gemini, and it was the first step towards collaboration to advance FHIR. So this Gemini is a true 50-50 parity joint initiative. and it's also a kind of a red telephone between these two organizations in general, but in particular, of course, for FHIR. So the mandate is on the common statement of understanding between IHE and HL7, which is in place for years already. So this is one actual project operating under it. And its mission is definitely to build up and strengthen collaboration between the two organizations to advance FHIR. It's a joint ownership, and we are all acting in an equal parity, in a friendly mode, and try to synchronize the different topics related to FHIR, which is, for example, tools for the development, tools for the publishing of implementation guides, common messaging to deconfuse the market, sorting out the different testing events, and give the right explanation to the audience, which testing event is for what purpose, on which level, and so on. So the main work is coordinate and establish connections, and to combine forces. And on top of this, 1 year later, there was another even more outreaching idea of collaboration, which materialized in a consortium. It's called Global Consortium for eHealth Interoperability, and it's also known as the HIMSS IHE HL7 collaboration. So it's 3 organizations now. It is also focused on FHIR, but it has a different purpose. So Gemini is more on a kind of a, if you want, on a technical level to get the FHIR development right. This consortium is kind of on a strategic level. It has been launched in early 2020, and the COVID crisis has unfortunately a bit reduced the speed of this consortium, which was ramped up quite good. But I guess we got interrupted, unfortunately. But it is a global community all around collaboration. So topics and work items of this consortium are, for example, listening session to COVID and to other interoperability topics, to create something like an interoperability dashboard, a global master standards list. So all work items, which are not all of them are unknown, but which were not really accomplished in the past because they are simply too complex or too big for one of the organizations alone. So in short words, everything which is too big, too complex for one of the organizations, the consortium should be the first level door to attach to it. So it's not a kind of replacing the 3 organizations, it's placed on the pillars of these 3 organizations, and all actual working on FHIR will still taking place in HL7, working on testing, conformity assessment will still take place in IHE. This is an overarching body to channel a little bit these different activities, to coordinate these different activities, and to be ready for other large and strategic collaborations of governments of countries to offer the standards community as a partner. It's not only these 3 organizations. We are the founders, so to speak, but there is select on the line now. Hello. Okay. It's intent. Okay, someone has the microphone open. It produces echo. Okay. It's intended to become a community, so all standards organizations and all kinds of institutions should be joining. We are just starting up this, so it's all in creation at the moment, but after all, this should be a prospering and living community all around interoperability. So what you have heard today is that there are quite a lot of IHE profiles already available based on FHIR. You have heard about kind of what they are about to do. Of course, it's not enough time to dig into all of them in detail, You have learned that there is a lot of room for engagement if you want, so you can get easily involved either on the profile development level or on the local level in case there is a local deployment committee in your country. Last, we have some links on the slides for you which might be interesting for your offline reading. And yeah, I'm not sure, Carleen, do we have some questions collected?
Yes, José Costa Texera would like to add something. José, you have
Hi everyone.
you have 3 minutes.
Hi Charles. Yeah, hi Charles. Hi Jürgen. Yeah, I just wanted to comment a bit from the perspective of Belgium that the this is indeed, as Jürgen has been saying, this is a collaborative effort, and I would just like to highlight a couple of things that Belgium has been working on, and they will actually hopefully help this collaboration. So first of all, on the topics that are very dear to us in Belgium, so the medication lists and the vaccination, well, which is now a dear topic to everyone, and the summaries. There has been some updates recently that the work that we are doing in Belgium is actually going to be coordinated with other countries that are working on similar things, on vaccines, on medication lists. So that will be under the auspices of IHE. So IHE again as a collaborating entity. And it will be good to see that what we do in Belgium is not only staying in Belgium, but it also gets the feedback and maybe influences also the perspective of other countries. So that is about the content. The process is also something, what Jürgen was saying, the guidelines for publishing materials, etc. The process that we've been following in Belgium is trying to align with the IHE process that Jürgen and Charles have been describing, so the idea is that we in Belgium are publishing our FHIR materials and trying to follow a similar process to what IHE has, which is this level of maturity, not just making profiles, but having a mature infrastructure or a mature concept of how do we maintain this, how do we put different standards together. So in Belgium, how do we put GS1, CMK as for terminologies, and SNOMED, and all these things together with FHIR. This is very important for us in Belgium. And finally, some of the things that we have done in Belgium, they have actually been useful for the whole IHE on FHIR effort. And I would like to thank the Belgian community, so IHE Belgium, HL7 Belgium, and the institutions like the AZG that have played an important role in pushing this effort and making sure that Belgium is more and more open to the collaboration. So I just wanted to bring this note here because all that we have seen here today is going is already affecting the way that we work in Belgium, and I thank the presenters for this. Sorry, that was a short summary.
Thank you, José. I have not seen any other questions. Thank you very much, Charles and Jürgen. So we do have a feeling that
I think there was an interesting comment.
Yes, Charles, please.
There was an interesting comment that there is an MHD deployment, VZNKUL.
It's the
an MHD deployment.
It's a hub from Brussels, and also the Brussels hub also has MHD, because last year when we had our kind of projectathon, Nick connected his patient app to the Brussels vault, while Nick is from the vault at Leuven. It's a Flemish vault, yeah.
Right.
Yeah.
And so I think what we're discussing here has legs in Belgium, and that's wonderful. Thank you.
Thank you very much. Thank you, Charles. Thank you, Jürgen. Thank you, José. We hope to meet soon. And tomorrow at noon, we have another session on IHE and its validation tools. Thank you so much, and I hope to meet you very soon in our upcoming sessions. Have a good day.
Thank you. Bye-bye.
Thank you. Bye.